Thank you, sir. Very good morning, or should I say good afternoon to everyone here today. Am I audible? Yeah, better. Thank you. And lovely to see a full hall. I would, of course, like to congratulate the team 3D Con and, of course, under the leadership of Vijayakumar, sir. A pleasure to be here and to welcome you all to the city of Chennai. This next couple of minutes, what I'm going to be talking about is the newer basal insulins that we have, which are now being referred to as the second generation insulins. And before I actually move on to the topic as such, what I'd like to sort of set context is that just for us as clinicians, I'm sure many of us sitting here have got experience in the field of diabetes and have been following up with latest updates in diabetes management. And I think it's safe to say that there has been an evolution over the past couple of years. It's been a rapid evolution. And it is now currently probably safe to say that it is one of the most exciting eras in the management of diabetes, because there's newer drugs being added almost every other day, or every other year, if I may say. But that being said, in spite of all these agents that we have, in spite of all these newer pathways that we are approaching our glycemic management with, in spite of our approach to management of type 2 diabetes itself evolving, the one king, if I may say so, of therapy, the king of therapy still remains insulin. And I think no clinician sitting here would disagree with me when I say the one drug or the one anti-diabetic agent with that infinite capacity to control blood glucose would always be only insulin. We know that we have so many other agents, but I think each of them with their limitations, and insulin still remains the mainstay of treatment. So with that as a background, it's always good to come back to the basics. So here we're looking at a slide in which we're looking at the evolution of the basal insulins. I don't want to go into the background of the history of insulin, of course. We know that insulin has evolved over the years. But amongst the basal insulins, the first basal insulin that is probably still quite commonly used, especially in our part of the world, is NPH. And that is what we're seeing over here, which is being compared to the other basal insulins that we have. I don't know if this is the pointer. Okay, anyway. So the first slide that the first graph that you're seeing is a comparison between NPH with glargine U100. Great, thank you. Fantastic. So this is the comparison between NPH. So NPH we all have experience using, isn't it? It is the most basic basal insulin that we have available, and we still use it, of course. The capacity of NPH to reduce the fasting. Any basal insulin, what is it that we're looking at? We're trying to reduce the fasting blood glucose, isn't it? So we know that with NPH, we do accomplish that target. However, there is that slight peak that happens with NPH. With a duration of action for up to around 8 to 10 hours, there is that slight peak. And this in turn, when we use in our clinical practice, can result, many of us I'm sure have experienced that our patients do go into that nocturnal hypoglycemia quite often with the use of NPH. Now when you compare Detamer with that of glargine U100, again glargine U100 has a flatter profile. Detamer, although still probably not is used as much, maybe used most commonly in pregnancy, does also have a slighter peak but a longer duration of action. Then we have the other two comparisons, which is probably the most commonly and the most important pertinent comparison. These are the insulins which are so-called the second generation insulins, which are now available over the past couple of years. And when we compare the two, so you have insulin degludec and we have glargine U300, comparing both, you find that you have the most flat profile. And this kind of graph, this flat profile of any insulin was something that we as clinicians had never seen before. The first time that I remember when degludec was launched, and then when we saw glargine U100 and looked at the PK/PD of both these molecules, or formulations, it was the first time ever we were so used as clinicians to seeing those graphs with these peaks, including glargine U100, that the first time we saw the PK/PD of degludec and that of glargine U300, we were pretty surprised. It's something that we as clinicians had never seen before. So that is how the profile of these two second generation insulins are. So what is the advantage? I showed you the profile and its action, but what does that translate to when used in the clinic, and what does that mean to the patient? What it means is that the profile of these insulins, the second generation insulin, especially glargine U300 that we're discussing here today, over the first generation insulins, which is U100 detamers. So U100, which is glargine U100 and detamers, are the first generation insulins. And the second generation would be degludec and glargine U300. When we compare the two groups, the second generation insulins, and you're looking at the advantages of these over here, is that because of that flat profile, what that translates into clinical use is that you have least glycemic variability, lowest risk of hypoglycemia, especially nocturnal hypoglycemia. Most importantly, flexibility of dosing. What does that mean? So earlier with the detamer or the glargine U100, we used to tell our patients to take it at a fixed time every day, because the duration of action is for up to 18 to 20 hours. Whereas with these insulins, there is that flexibility of dosing. In fact, you can ask the patient to take it within a window of that particular time. Say they take it every evening, take it within the window of about 4 to 5 hours within that period is what you can tell them. There are studies that show that you can take it one day in the morning, one day in the evening. However, we do not advise our patients to do that. So these are the various advantages. And another biggest advantage is that you have the least weight gain. Weight gain is probably one of the side effects that we know with insulin use, and the least weight gain that you see is with these second generation insulins. So these are the various advantages of the second generation insulins that we have available. What is glargine U300? This I think we are all very familiar with. It is nothing but the same molecule but in a different packaging. What does that mean? You have 300 units per ml as compared to 100 units per ml that we have with glargine U100. So it is a packed molecule. As a result, your volume is less. And again, what happens is when the patient injects this into the subcutaneous depot, you have a much smaller surface area. And as a result, the dissociation as compared to glargine U300 and U100, the dissociation is a lot slower, which is why you have that much flatter profile. Now, this is what was actually unexpected. What did we initially expect, before the launch of U300? When the company was coming and saying, we are going to launch, and we heard about U300, in our heads as clinicians, we thought, oh, it's the same molecule. You're just going to concentrate it, so the volume is going to be less, is the only advantage that we had expected. However, what I showed you in the previous couple of slides is that even the PK/PD has changed while packing it into a concentrated formulation. So when you have a concentrated 300 units per ml, you have a much flatter profile, and that is what came as a surprise, and that is what makes this formulation stand out. So now that we looked at the PK/PD, looked at how this works, and looked at all these that we looked at so far, now we need to see what is the clinical evidence that we have, isn't it? Because at the end of the day, we want to know how to take this back to our clinic on Monday morning. So this is the various, and there's no dearth in this, there's various clinical trials. You have trials looking at the real world evidence, to RCTs, to PK/PD, and each one comparing it to different subgroups in different groups of patients, and to comparing it to different molecules, including degludec and U100. We'll quickly run through some of them to sort of understand the efficacy and risk of hypoglycemia and so on. The first most important is the BRIGHT study, and this is important because this is a fair comparison. What we want to know is what is the difference between U300 and degludec, because both have similar PK/PD. I showed you both have a flat profile, but how do we know which one to choose? Is there a difference between the two? And this is the most important question that we'd like to answer. So here is a study, BRIGHT study, in which subjects with HbA1c between 7 to 10, type 2 diabetes, were randomized into two groups, and the comparison was between glargine U300 with that of degludec. And at the end of the study, what was found that the HbA1c reduction was similar between both the groups, right? So the efficacy-wise in terms of glycemic benefit that we get is actually comparable between glargine U300 and that of degludec. And that's what we're seeing over here as well. Over a period of 24 weeks, reduction in HbA1c was almost similar, of course numerically different, but almost similar between both the groups. However, what they did find in the BRIGHT study was that the risk of hypoglycemia was significantly lower with U300 as compared to glargine, with U300 as compared to degludec. And this I want to spend a little more time here, because what is important to note here is what is important for us in the clinic. The most common period where patients go in for hypoglycemia with a basal insulin is during the initial titration period. And this I'm sure many of us as clinicians are aware of. When we initiate our patients, because to target the ideal fasting once we initiate a patient on an insulin, not just with with a basal insulin, but with any insulin, it is that initial first few weeks, the 8 to 12 weeks of titration until we reach that ideal dose, which is the most challenging time for both the clinician and the patient, because that is the period in which the risk of hypoglycemia also is the maximum. And that is the period in which, during the BRIGHT study, the first 0 to 12 weeks or the period of dose titration was which they found in the study that there was a significantly lower risk of hypoglycemia with glargine U300 as compared to that of degludec. So the results from the BRIGHT study did show that both are efficacious and have similar capacity to reduce the blood glucose, but the risk of dose titration hypoglycemia was lower with U300 as compared to that of degludec. Next question would be, what do we have in terms of Indian data? And this is the Indian counterpart, which has been conducted in our part of the world, in which people with type 2 diabetes, it is a prospective study. However, there was no comparison group. It was just to look at efficacy and risk of hypoglycemia and adverse effects, especially hypoglycemic effects, with in about 200 subjects with type 2 diabetes. And at the end of the study, it was found that there was in fact significant reduction in HbA1c, a significant reduction in fasting plasma glucose, but most importantly, there was no change in body weight. And last but not more, the most important point was actually that there was an improvement in quality of life and patient satisfaction. And this is important, especially in the Indian context. We know how, well, I guess in the global context itself, but more so in the Indian, we know how challenging and how averse patients are once we mention the name insulin itself. So when we initiate insulin, and if patients are satisfied with that, that actually goes to say about the molecule itself. More importantly, the safety profile also was actually not as significant to result in discontinuation of therapy. So this was called the safeguard study, in which glargine U100 was well tolerated with lower risk of hypoglycemia with meaningful glycemic benefits in people, in insulin naive Indian subjects with type 2 diabetes. So far we spoke about glargine U300, we spoke about the PKPD, we compared it with degludec, we also looked at Indian data. But our concern is also the special population. So the elderly and renal impaired patients. Why this is very important for us as clinicians is because this is the subgroup of subjects in whom we are most concerned about the risk of hypoglycemia, and we want to keep glycemic variability to the minimum. And of course, you have also the subset of fasting. We know in our part of the world, especially in spite of being diverse, among the Ramadan fasting, and as well as the Hindus also do fasting, the Christians also do fasting as well. So that is also a topic of interest. In the elderly, we have some data. This is comparing in people with type 2 diabetes itself with U300. This is the addition trial. While comparing the subgroups of between subjects with age of more than 65 and less than 65, it was found that there was similar reduction in HbA1c, in fact a little better reduction in HbA1c in the elderly, with most importantly lower risk of hypoglycemia in the elderly as compared to that of the younger population. The BRIGHT study, which was comparing it with degludec, also showed a similar reduction in HbA1c. So above the age of 65, above the age of 70, slightly lower HbA1c reduction with glargine U300 with a lower risk of hypoglycemia as well. So safe to use in the elderly as well. In people who are fasting also, this is in people during the Ramadan fasting, in which they found, this is the Orion study, this was conducted both globally and in South Asia, some centers in India as well, in which they found that there was a significant reduction in the HbA1c without severe hypoglycemic events. So safe to continue even during fasting. Importantly, in patients with renal impairment, the BRIGHT study again found that across HbA1cs, more than 90, 60 to 90, even in subjects less than 60, there was a significant, it worked well, did reduce the blood glucose. But again, what we are more interested in this subgroup, in the special population of CKD, is that we do not want the risk of hypoglycemia. We know that in CKD, the biggest challenge is one, high insulin resistance, but at the same time, we know that these are people who are at risk of hypoglycemia for various reasons, especially the azotemia and renal clearance, which is compromised. And here what we're looking at is results from a sort of, you're looking at the forest plot comparing across EGFRs, and you're seeing that when you compare between glargine U300 versus degludec, the risk of hypoglycemia is lower, more in favor of glargine U300 as compared to degludec. So safe to use even in people with CKD, and this is something that we do see in our clinical practice as well. There are some more trials, the European REALLY trial and then the XSTAR trial. These are trials in people with CKD to just show its safety and lower risk of hypoglycemia. Pregnancy is, of course, the last subset of special population. Of course, we know that although not approved in pregnancy, there is some clinical data in which they have actually studied it in almost 50 countries, looking at around 500 pregnant women. Use of glargine U300 was found to be safe. Although Levemir would probably be the best basal insulin of choice. This is the device. You have glargine U300 in both the cartridge as well as the disposable pen. Very convenient device, which is smooth in its gliding and in its dialing up and down as well. Can dial up to 80, and the plunge is also pretty smooth. So I remember that earlier there used to be a time where I'm sure many of the senior doctors here may also agree with me that earlier with the use of glargine in the early years, there used to be some issues with people experiencing some stinging with it because of the acidic pH, number one, and also with the device there used to be some sort of hitches. But now, not happened in the recent, in the past couple of years, those things have settled, and with U300 never have I come, I haven't, I'm sure most of you also have not come across that complaint, and the device is also pretty, very, very user-friendly, patient-friendly as well. So in summary, glargine U300 is the concentrated form of glargine, which is 300 units per ml. This is a special formulation, and although we would probably expect it to be similar in its PK/PD with that of U100, it is not so. You find that it has a much flatter profile, and what that translates into the clinic is that you find a much lower risk of hypoglycemia, effective HbA1c and fasting plasma glucose reduction with least glycemic variability. With all these benefits, it can be safely used in people for glycemic management, more so with those with risk of hypoglycemia. With dose titration, we find that the risk of hypoglycemia is also the least. And I think my concluding remark would again be my initial statement that I made, that although we are in an era where we are equipped now and we have all these newer molecules, we have the SGLT2s, we are in an exciting era, we have the incretin therapy, and we are moving towards more and more agents that we have almost every other day. So it is an exciting time, but we should probably remind ourselves to not lose focus of the goal, which is at the end of the day, glycemic goals also do need to be, we shouldn't forget about the importance of glycemic management. Having said that, insulin is one of the kings of, like I said earlier, still remains the mainstay, or the most powerful agent that we have to control blood glucose, and we shouldn't sort of forget and sway more towards the newer agents and forget the use of these agents as well. Amongst the insulins, the basal insulins, we have the second generation basal insulins, and U300 is a great formulation to give us good outcomes in our patients as well. Thank you.